We're very excited to kick off the day with our first keynote, Alexander Heaton, and I'll just do an introduction and read out his bio, and you have absolutely incredible knowledge to share from across oceans today. So, Alexander spent the last 3 years as the Director of Reimagining Public Safety at the Policing Project at NYU School of Law, where he launched a national campaign to divert 12 million calls, and I repeat, that's not a hiccup, 12 million calls annually from police to alternate responses by 2030, designed and implemented the nation's first complete crisis response ecosystem in the city of Minneapolis, and served as a subject matter expert on non-police responses for governments around the world. He joined the Policing Project from the City of Chicago, Office of the Mayor Public Safety Team, where he was the co-founder of the first alternate response unit for the City of Chicago, and served as a policy advisor to the mayor on arrest diversion and initiatives that sought to incorporate all city agencies into the creation of public safety. Before this, he spent several years at the University of Chicago Crime Lab, leading major public safety reforms, including the country's largest narcotics arrest diversion initiative, and his earlier career focused on international conflict and public service. He holds degrees from the University of Wisconsin and the American University School of International Service, and is currently pursuing his PhD at the University of Pennsylvania. We thank you, Alex, for joining us. And just to let the audience know, we'll have about 25 minutes for questions at the end, and we'll open up a Q&A function for people to put those in. In the meantime, sit back, listen, and we really look forward to hearing from you, Alex, and what you have to share with us. Thank you.
Awesome. Thank you very much. Let me just get my screen up here. All righty. Can you see that?
Yes. Thanks, Alex.
Excellent. All right. Thanks a lot, everybody. Yeah, please go ahead and drop your questions in the chat, and I will work through them at the end, if that's all right with everybody. Yeah, thanks again for the introduction. This is me. I don't think we need to go through this. I think that was a really great introduction. Thank you very much for that, Chloe. This is I'm really, again, really excited to be here today. So just an overview of the agenda here. First thing, I'm going to talk about the organization that I work for. I'm going to talk about what we're trying to achieve with an initiative like this. We're going to go over the response mismatch that we currently see with utilizing law enforcement officers to respond to basically everything because they are one of the few 24/7 entities that can respond. Then I'm going to introduce our reimagining public safety model, which is a model that we have designed and that we are implementing that we believe addresses a lot of these concerns through 4 main components. Again, we'll get into these later, but they're pre-dispatch diversion, which is resolving concerns without having to dispatch anybody. Alternate response, which is self-explanatory. It's a response other than a police officer. Alternate destination, taking somebody somewhere other than lockup, jail, which I'll use interchangeably, or the emergency department. And then second response, which is a follow-up. Following that, I'll talk through a system for governance and accountability, and then we'll get into what it looks like in practice to do something like this. And then I'll talk through what you need to get started in your jurisdiction to stand up something like this. Okay, so I work for the Policing Project at the New York University School of Law, and what we do is we try and make public safety more accountable across the country. We try and make it more transparent through the use of transparency initiatives, improve communication, and obviously, most importantly, to make it racially just. We want to make sure there's equal access to justice in the United States, and we want to make sure that folks are equally safe when they contact 911 or the emergency responses. At the Policing Project, we have 4 big buckets of work. The one that I lead is reimagining public safety. So we work with municipalities to really think about how they're creating public safety and what goes into that outside of just the 911 response. And I'll get into that a little bit further later on. The second thing we do is community-based projects. So we help scale community-based projects and replicate them elsewhere. and we connect them to evaluators and other academic partners. And when I say community-based projects, this is kind of like the bottom-up solutions that come up, and we help scale them and test them, and then see if they'll work in other places. Within that, then we incubate those new approaches, and so we provide administrative assistance, management assistance, communication. We have a full suite of tools available through the university that we help provide these up and coming programs with. And then finally, we draft model legislation. So as we see the use of new tools or practices, we want to make sure that there are guardrails around those to make sure, again, that they're being used in a manner that is accountable to the public, and that keeps the public safe from nefarious uses or from irresponsible uses of tools and things that have been introduced. Okay, so let's talk today about what we're trying to achieve here. And the chairman just spoke about that. And I want to just kind of talk about how we think about it on the Reimagining Public Safety Initiative. The first thing here is like we need to center the resolution of public concerns. Like the public is calling 911 or 000 because they have a concern that they're not able to resolve on their own. And this raises to the level of I need government assistance to resolve this. So our focus in building out a system like this has to be on resolving that concern first and foremost. And so we want to make sure that that is centered. That's the first thing we mention in all these conversations. The second thing is, and I'll get into more of this in a second, is we want to make sure that our officers are spending time investigating and deterring violent crime above all else. We don't want them to be social workers. We don't want them to be, emergency room doctors. We want them to be focusing on the thing that they are trained to do, and that is investigating and deterring violent crime. And that goes into our third bullet point is we don't want them involved in unnecessary things where they're acting as maybe an agent of an insurance company or something that we just don't, there's not a clear connection between that activity and safety. And then finally, and obviously most importantly, we want to reduce these negative outcomes. What we can officers to respond to things where they are not the best suited to respond based on their training. Again, if there's a mental health concern, we send a mental health practitioner. It's similar. We don't send officers out if you're having a heart attack. We don't send officers out to kind of say, let's help fix heart attack. We don't send officers out to respond to a number of medical concerns. This is very much similar. We want to make sure that we are sending mental health professionals out to mental health calls in order to make sure we reduce the likelihood of these horrible outcomes from happening when they go wrong. And the one big takeaway from this is that like when there are these like negative outcomes that that occur, the entire system becomes less effective. When an officer uses force and gets injured, the likelihood of their partner using force in the next couple of weeks skyrockets for any other call. When there is a use of force in the community, 911 calls drop immediately following. When there's a use of force in the community that results in a fatality, 911 calls drop for several months afterwards. So the entire community becomes less able to access justice because of these sorts of outcomes. So in that sense, whatever we can do to make it safer for individuals to call 911 or 000 is going to make the entire system safer if you have to call for something where you do need an officer later on. And this is what I mean when I talk about the things that we're sending police out to. This is an example of how officer time is being spent in the city of Philadelphia, where I live. So if you look at, this is how an officer's year is spent on these call types. And so you can look, and there are some that have a connection to violence and safety, person with a weapon, robbery in progress, theft in progress. These are things that, yeah, we want to have an officer respond to. But there's a lot of things where it's not entirely clear that the officer is the best response. A hospital case, going to hospital somebody to kind of observe them in hospital or speak to somebody in hospital. We don't need an officer to do that. responding to auto accidents. In an auto accident, the majority of the time, the police officer is there acting as an agent of the insurance company. They have to fill out a report, give it to you that you then take to your insurance. This is not something that we need somebody trained as an officer to do. Illegal parking. When we have officers respond to emergent parking, maybe you can't get out of your driveway because there's somebody parked in front of it and you're in a hurry to get somewhere. So you call the emergency response service and the police officer comes out to address that. These are things that we don't necessarily need a police officer doing, and that's all time that they could be spent investigating something with a connection to violence instead. A big one that we see over here is automatic burglar alarms. In the United States, the vast majority of automatic burglar alarms are set off by the cat or by leaving a window open, by something like that. And they're an enormous time suck. And so these are things that that there are other responses and other ways to address it that don't necessarily dispatch the police. The last thing I want to say before I get into it is we need to be reasonable about what we expect to come from an alternate response program. Alternate response on its own, sorry, the dog. Alternate response on its own reduces the risk of an individual calling 911 or 000 to have their concern resolved. That call will be safer for an individual with a mental health concern if it's a mental health responder who's trained in dealing with mental health crises. But that's not a complete system, right? If we want to have somebody go and pick up somebody who's maybe trespassing because they're experiencing homelessness, it doesn't help if you don't have somewhere to take them to. You're just going to keep picking up that person from different places as they get caught. And yeah, those responses are going to be safer. It's not going to be the police having to respond to that. They can focus on other things, but you have to have somewhere to go. So the completely reimagined system must involve connection to resources that exist in the community or the creation of resources in the community. And then your system will only be as effective as the resources within the community that you're able to connect people to. And that way, when you have this entire system, you're not just reducing the likelihood, you're not just reducing the harm of calling 911, you're reducing the likelihood of that individual having to call 911 later on in the future because you've resolved that concern. You've given them access to tools in the community where they can address that concern on their own without having to call 911 in the future. Okay, so now we're going to get into the model itself. So this is the reimagining public safety model. It covers 4 intercepts as an individual comes into contact with the system, and each one is an opportunity for either an alternative response to happen or for a traditional first responder to take somebody to kind of move them out of the system. I'm going to go over these real quick, and then we'll go deeper into them in the following slides. The first one is pre-dispatch diversion. So again, this is any concern where an individual feels that they have to bring it to the government to help them achieve resolution of that concern, but it can happen without a response being dispatched. So they can resolve it over the phone or resolve it online. This issue can be resolved, everybody's satisfied with it, and nobody has to be dispatched anywhere. Again, the second one is the alternate response system. This is when we say alternate response system, it's anybody that comes, it has to come through either the emergency dispatch system or a unit that could be dispatched to the emergency dispatch system. And so what I mean by that is maybe you call 911 and they send out a mental health responder, or your mental health responder is out on the street and sees somebody who is in need and stops in response to them there. So those are contacts within the alternate response system. The third one is an alternate destination. Again, I use lockup. Jail is the same thing for us, but basically it's a destination that any first responder is eligible to take somebody to that isn't necessarily a police lockup jail or a traditional standard emergency department at a hospital. And then finally, second response is what we call any sort of coordination, outreach, telephonic outreach in person, anything that happens following contact with the 911 system. Okay, so pre-dispatch diversion, there's 2 ways, and I know this is about kind of crisis response, but there is an online component to pre-dispatch diversion that also addresses a lot of concerns. So I always include it in here just because it doesn't require the creation of any additional units or any additional people. And it's just something to think about as we think through how to make our 911 system safer. I always include it anyway. So there's two ways that we think about pre-dispatch diversion. The first one is online response. The second one is the embedded clinician. As I said earlier, online response replaces the officer's report writer function. And many car crashes, if you can imagine, if you look at car crashes, for instance, in the city of Chicago, where I'm from, 150,000 car crashes a year. Of those, 50% of those cars are able to be driven home immediately. There's no crime taking place, there's no injury. And so the safest thing for the community is to go home and file that from your own house. And so there is an immediate opportunity to shift between 4 and 6% of calls in the city of Chicago over to online response, and you'll never, nobody has to respond to those at all. It's all done online. Dallas has a really good example of this as well, where they've got tons of call types that can be filed online to, again, reduce the likelihood of having to dispatch officers or dispatch anybody at all. And where the desire from the organization or from the caller is primarily a report number. The second one that kind of focuses more on the crisis ecosystem is the embedded clinician. So an embedded clinician, a great example of this is in the city of Austin in Texas. Embedded clinicians sit within your dispatch center and they screen calls for any sort of mental health component. As soon as there's a mental health component identified, the call is moved over to an embedded clinician call taker who also has the authority to dispatch. And they screen these calls to see, number one, can this be resolved over the phone? A very common example a lot of people are familiar with is like suicide hotlines. Folks are able to call suicide hotlines and kind of be de-escalated somewhat and then connected to community resources. This is very similar to that, but it's in-house in your municipality. And Austin found that they were able to resolve about a quarter of their mental health calls over the phone without having to send anybody out at all. And then they were able to connect them into follow-up care to make sure that that resolution was successful. So this is something that's an enormous cost saver as well to these interventions, and it's a way to get things going without having to build out a lot of logistics that go with an in-person response. Second one is our alternate response. So there's three ways that we think through alternate responses. There's the ones that we're talking about today. This is our mental and behavioral health response. Low priority call response is the next one. This is for if there's kind of disagreements or concerns that are happening in businesses, in homes, maybe between arguing neighbors. And then the third one is our in-person car crash response. Where their function is primarily traffic control and debris removal. The city of Albuquerque designed what's called the Albuquerque Community Response, and this is it's a unit that stands up similar to a police department, fire department. They are at the same sort of seniority, so they are their own department. And they respond to folks having mental distress, anything with homelessness, suicide attempts, overdose responses. Welfare checks is a very big one. Welfare checks in a lot of cities is what leads to a lot of uses of force. And so this is something where if you have reason to believe that it's a mental health call, or that there's a mental health component to welfare check, maybe somebody just lost their job and I haven't heard from them in a few days, and this is unusual. You send out your Albuquerque community response folks, go in there and check on them. What we're seeing with a lot of agencies now is that they're also taking on death notifications. At some point historically, this was a police responsibility. This became a police responsibility in a lot of jurisdictions. And a death notification is a massive mental health, a traumatic event. You know, you're hearing somebody close to you has died. We should probably have a mental health responder responding to that. And so there are a number of these programs across the country right now. Albuquerque is one of the most exciting, successful ones because it's been stood up as a full equivalent first responder unit under their government. Alternate destinations are, as we said, anywhere it's not a jail or an emergency department. These are so important for a number of reasons. The first one is that any first responder can transport somebody there. And so this is such an important part of your kind of mental health crisis ecosystem, because what you don't want to be in a situation where you have to wait for your maybe you have to wait for your behavioral health responders to show up. It's like, no, we've seen this as an issue. Let's get these folks over there immediately and get them right into care. And so I put up a few examples here of really promising ones. The first one is Denver Behavioral Health Solutions Center. And what this is that somebody is identified in the community, maybe that there's some sort of low-level nonviolent crime that's been committed, and the officers or the mental health responders or even fire and EMS recognize that this is probably due to some sort of unmet mental health or behavioral health need. These folks are, instead of being taken to jail or to put under police hold at the hospital, they're taken over to the mental health triage center, and it's got multiple levels. So you can be in there for up to 24 hours to be screened into care. You can go upstairs for up to 7 days as they try and find you a local outpatient center to kind of get you into treatment. And if you don't find that, then there's another level where you can stay up for 30 days where they continue to try and connect you with ongoing care. The second example here is the San Francisco Sobering Centers. Sobering centers are important, a really important component of your behavioral health crisis response, because this is something where, unless there's some sort of violence that takes place, this you can be connected there as many times you need, and it's always going to be more cost effective and safer to have a medically observed detoxification location than it is to take them to jail or to the most expensive medically observed detox in an emergency department. While you're in the sobering center, again, once folks are sober enough to consent into treatment, they're able to be screened by mental health, behavioral health providers, and connected to care. And again, this is, we'll get into high frequency utilizers a little bit later, but this is a place where you start to be able to see your high frequency utilizers come through and you can connect them with more aggressive forms of outreach. And then finally, Harris County Arrest Diversion Center is a diversion center that's a little bit broader than just mental health or behavioral health. So this is a place where, when there are crimes that are being committed outside of just mental health, behavioral health, if there's something going on with shoplifting or something, to possibly what we call survival crimes, to feed some sort of substance use disorder, or even if there's things that are happening around sex work, if it's illegal in your jurisdiction, folks are being taken to these diversion centers, screened to make sure there's not a trafficking concern, and then they're being released. So these are three prominent examples of alternate destinations. Again, so important. And the last thing that I'll add to these is that they need, with the exception of the arrest diversion center, these need to all have a walk-in component to them as well. So once you take somebody there, let's say I get taken there to the sobering center. Hey, we took Alex to the sobering center. He had too much to drink, and we want to make sure that he can safely be observed. Next time, my loved one or whoever doesn't have to call 911 to take me there. They can just be like, we're going to put him in the car and take him down there. And again, now you've completely reduced the contact with the 911 system, and you've put a resource in the community for folks to resolve their own concerns. So I cannot sing the praises of sobering centers or alternate destinations enough as a central part of these systems. And finally, is the second response. Second response, again, is following up on folks once they were connected to the system. A great example of this that you see growing in fire departments, really internationally, but fire departments in the US are starting to do this, and they're calling it mobile integrated health. Some folks are calling it community paramedicine, and it's also being built into standalone mental and behavioral health programs. But it's basically, you had an interaction that was flagged for being either acute mental illness, substance use, homelessness, a number of things. And we're basically going to do outreach to make sure that the first place that you're connected to worked. And if not, we're going to figure out why. And so again, like, did the service you're connected to work for your needs? If you're on medically assisted treatment, is this the medication that works best for you? If they don't have it there, let's find somewhere that we can take you. Is it culturally appropriate? This is a big thing in places that use nonprofits to provide their services. So, is this LGBTQ friendly? Do you want to go to a place that's just women? Do you want to go to a place that has more language access? Do you want to go to a place with folks that look like you? These are all things that we need to take into consideration to make sure that the person remains engaged and has their concerns resolved in a manner that reduces the likelihood of them having a follow-on contact. And this last one, you have to say this because it's so important. It's silly to say out loud. Is it nearby? Like, sometimes when folks are being connected with these services, it's across town. You're like, yeah, that's great. You found this really neat service, and I've got to take 7 buses to get there. So the likelihood that I remain engaged in this sort of treatment is slim to none. And so these are just things that you want to be considering in your second response program. But a really good example of this is in the Atlanta Grady EMS system, where they have a number of calls that they respond to, and then when they respond to this call, they bring along a social worker who then immediately inducts you into their follow-on program, and then they do what we call relentless engagement, which is just kind of where, like, they are going to make sure that you are either in a program that works or they find one for you, and they're going to keep reaching out to you to make sure that happens. Okay, take a big deep breath for a second there. That was the model. Now, once you've got the model in place, and I'll talk about this in a second, but you have to make sure that all the parts speak to each other. And this is so, so important. So I just, again, I've been working a lot in Minneapolis. Minneapolis has an incredible collection of individual programs that each agency has built to address a specific problem. And what we found was that there's tons of overlap in the work they were doing. A lot of folks were seeing the same people, and there wasn't really much coordination. You know, if you can imagine, like, having to explain your trauma to 10 different agencies each time you do an intake, it's just as traumatic, to do this the 10th time as is the first and second time. It's like we don't need to keep recreating this. So what you need to build onto all these, which is essential, is a system for governance and accountability. And so what that means is that, number one, you write policies that tie all of these programs together. And not just that, but you write programs that tie them together with a criteria, not with discretion. So if Alex fits the criteria to go to this alternate destination instead of to jail, he goes. And not like, if somebody feels like taking me there, or it's not the end of the shift, or whatever, like, he goes. And so you write those policies that tie everything in together. And the second one is that you hold first response agencies accountable for utilizing them. And this is really key. Some of these accountability systems already exist in Australia. Australian Police Service use a version of what we call CompStat in the United States. Some agencies call it operational performance reviews, some call it crime reviews, but it's basically a time when you get to talk through the incidents and talk through your response and discuss how you're going to change and modify that. So the utilization of alternate destinations by police, as soon as there's a policy for it to happen, should be incorporated into these reviews. It's not enough to say we're doing it and here's some counts. These things need to be incorporated in there, and they need to be done by percentage rather than by counts. And I'll get into that in a second. As you build out your mental health, behavioral health ecosystem, it needs to have its own version of a performance review within whoever's hosting it in the government. And it's one of these things where folks need to attend. It needs to be like a mandated attendance. And then finally, is that calls need to be reviewed on an annual basis. This is the importance of engaging your academic partners, is that there needs to be a review process to identify additional calls to keep kind of moving over into these alternate responses. So what are the questions that you want to ask when you're managing something like this? These are the minimum questions, and I'm not going to go deep into the weeds on this. I think a lot of this is self-explanatory, but we want to know how many calls are being resolved by our embedded clinicians and how many calls are being resolved by our alternate responses. We want to know what percentage of eligible calls are being resolved by both, and then why are they being deemed ineligible. And why do I say that is because this is where you find a lot of like hiccups that weren't necessarily that aren't necessarily easy to identify. We worked with the city and we couldn't figure out why some of these communities were experiencing much lower eligibility for these alternate responses. And it turns out that in one portion of the city, most of the calls were happening in public spaces where dispatchers were more comfortable sending our alternate responders. And the other part of the city, which was majority Black, and with almost no public spaces, the dispatchers weren't sending alternate responders into people's homes. And so we immediately identified a training deficiency and an accountability deficiency that we had to correct to make sure, again, everybody had equal access to these sorts of alternate responses. That needs to be done on a monthly basis. And then annually, you want to review your calls to see what else can go in there. And that's going back to the death notification. That's how we discovered the death notification component on there. We spoke with police officers, we spoke with fire department members, and we spoke with alternate responders, and this came up where the police officers like, I genuinely hate this. I don't want to do this. I don't know what to do. And then alternate responders like, well, this sounds like something that any other entity would have a mental health provider tell you about. Yeah, so this is the questions to ask for that. Again, questions for alternate destinations are fairly similar. We want to make sure that the police, if there's a fire version of the operational review process, that once these policies are in place for utilizing alternate destinations, that this is incorporated into their review process. With the one addition here, and this is kind of gets back to what we spoke about in the beginning about making sure that your resources are available that you're going to divert people to, is that you want to also be tracking how many people are being turned away from a facility and why. You can have the greatest facility in the world, but if they shut at 5 p.m. and that means that all of your overnight shifts have nowhere to take them to, it's useless. And so this is something where as you're kind of as you're building out your ecosystem for individuals experiencing crisis, that you've got it documented that, yeah, we need another solution for our overnight shifts because, Salvation Army shuts at 5 p.m., something like that. And again, looking annually at what other offenses from the police or patient concerns from EMS and your alternate responders should be considered for alternate destinations. And our final set of questions here is for follow-up. So follow-up, this sort of data exists already. It normally exists in your public health system. It exists in your family services system. This is bringing it into putting sunlight on it within the first responder community, because this is ultimately the system that is going to reduce the likelihood that somebody re-engages with 911 or 000 later on. So we want to know what percent of the folks who are being referred to follow-up are being followed up on. And not all follow-up has to happen in person. Some of it can happen over the phone, but we do need to know, like, are these folks being followed up on, or do we have to figure out some sort of solution to increase the number of follow-ups? Again, because that is going to reduce their likelihood of calls. The second one is, what do we know about our high frequency utilizers in the system? In Chicago, we found that 1 out of every 1,000 calls at one point was coming from our high frequency utilizers, which is, for a city of almost 3 million, is humongous. Our top 10 highest frequent callers were in an ambulance on average every day and a half. And so, as you can imagine, the burden on the system is massive, and the likelihood that something bad happens with the amount of interactions they have is much higher. So how are you tracking who's in your high frequency utilizer population, and then what are you doing to engage them and to kind of make sure that your outreach organizations, your first responders, when they come in contact with them, how are you flagging these folks to make sure they get relentless engagement into some of these services? Again, on the Chicago example, it would have been cheaper to have a mental health worker move into their house for all 3 shifts and follow them everywhere than it was than what we ended up spending on them to put them into hospital 270 times a year. The last component here is transparency that we push on all of this. Um, so you're reimagining your system of public safety, and this is an opportunity to reimagine how we talk to the community about how you're creating public safety. First responders are hard at work on this. You know, your alternate responders, as they get incorporated into the first response system, are going to be working really hard. How do we communicate the work that they're doing? This is going to be something that involves building trust. It's going to be rebuilding trust in some communities, unfortunately. And most importantly, is getting in front of the rumor machine. Um, and the way you do this is through automatically updated dashboards. It's the easiest way to do this. It's data visualization is key for some of this. Um, and this you can kind of in the process as you're designing this, we ask 4 groups of folks questions as to what they would like to know. First one is members of the community. Go around, speak to members of the community. What would you like to know? What are the things that you are most concerned about? Because not everybody wants to wait 6 to 8 weeks for you to have a press conference, and then it ends up just being a bunch of people standing there for photo opportunity, and you get maybe one of your questions answered. Um, Journalists, like there's normally a love-hate relationship between government entities and journalists, but you need to go out and engage them. You know, speak to your data journalists, especially. What do they want to know? What can you help them figure out? What do our elected officials want to know? Are there any specific data pieces that you can put in there that can address those concerns right off the bat? And the last one of this, which is like, what is coming through the Freedom of Information Office? When I worked in government, we got FOIA'd every single morning to see what we'd spoken about this program the day before, and our Freedom of Information Officer hated me. He said like half of his work was dedicated to our emails during the launch of this, and so let's figure out like what are they asking? Is there anything that we can put in there and meaningfully convey it through visualization? And this is just I can't overstate how helpful this is. When we launched the arrest diversion program in Chicago, we went around to the churches and we spoke about what folks were most concerned about. And we were told that the rumor was that we were basically building a program that would divert white women who were arrested for opioids in black neighborhoods so they wouldn't have to spend time in lockup with other black folks in lockup. And so we knew from the data that the vast majority of folks who were being diverted from arrest resembled the community that we worked in. So we just spoke to our data visualization team and they added a race and ethnicity component to it. And overnight, the rumor went away. And it was that time that folks would spend kind of poo-pooing the program was something that ended up, you know, it was just one less concern that we'd addressed. And it was all done just through data visualization, constantly forwarding out the link to it. So I just can't overstate the importance of building transparency and communication from the beginning and doing it with all the people who are going to give you the biggest headache when this is launched, because it is. Folks are going to have a million questions, and that's okay. But we can probably maybe reduce to 500,000 if we proactively build it into a transparency initiative. All right. Thank you for listening. This is last 2 slides here, so stick with me. But what is this going to look like in practice when you build out your alternate response program? And so the first thing is to remember is that not all of this has to happen at the same time. This isn't going to be a light switch. It's going to be a slow roll. Some things are going to be low-hanging fruit that you can get done immediately. Some things are going to take longer. Um, so some calls are going to no longer require an emergency response. We're going to say these calls we do not think are best resolved through dispatch. If that means like, hey, I just moved into town, I don't know where the nearest pharmacy is to get my antipsychotic meds, we don't need to send an officer out to that response. If the person's panicking and calls 911, we can resolve that over the phone. Some calls can be responded to by other existing responders, and the heart attack is the best example. Like we don't send an officer in first if somebody's having a heart attack. We send in a firefighter, EMS, or somebody like that. Let's let's look at these calls and see, are any of our existing first response calls that are responded to by police currently, can they be taken by fire? Can they be taken by EMS? Is this something that we can just shift over with existing resources? And then finally, is that some will require a new response altogether. And that's what we're talking about with our mental health response, is that you are going to have to build out a new response. And there's going to be, a lot of logistics questions that come with that. Um, but what we're saying is when we design this new response, this is basically going to be the three outcomes for all of these calls that we're looking at. And so what do you need to get started? These are the kind of five most important things that you will need in any municipality or jurisdiction to get going. The first thing is support from an agency leader and executive. Now, the executives are probably the most important because they can inform the agency leaders that they support this initiative. But the ideal is that the agency leaders are supportive of it from the beginning. And so whenever we work with municipalities or governments, we get this in writing and then we share it on whatever our social media is. We get them to share it too, that we're excited to work together to do X, Y, and Z. Because then you can always refer back to this if there's any concern, and you can go to whoever your government executive is, whether it be your mayor, or your governor, or whatever, and speak to them about that, what's happening. The second thing is an executive steering committee of all of the agencies that are involved. And it has to be staffed by people with the authority to make decisions. So you can't have somebody that comes who just says, I need to go back and ask over and over, because then you're going to quadruple the length of time it takes before you get wheels on the road. The third thing is a calls for service analysis. This is so important. So what you need to do is you look back 3 to 5 years of any data for any government agency that touches someone who has a mental or behavioral health concern through your 000 system. So it starts with them at the call center, and that includes police, fire, EMS. And if there's already a kind of mental health or public health agency that's involved and they have data, look at that too. But what we need to do is we need to look at these calls, look at the outcomes of these calls, see where folks are already being transported, and basically we build out pathways for how we're going to reroute these calls to other responders and what that's going to look like in terms of time savings and risk changes in risk calculus. Number four is this is a long word for just a long set of words for just another university. So you want a local university partner to evaluate the work. You don't want to do this evaluation in-house because number one, the likelihood of a government entity putting out an evaluation that said that it didn't work is slim to none. And number two, because you want to validate it and build trust in the community by having your local academic partners say, yeah, here's the things we found, but also here's all the challenges that we found that they're going to have to address to make this more effective. And then the last thing is the policy lab. I work at University Policy Lab. They are so important to help build out this new safety ecosystem. These are normally staffed with folks who have done this work in municipalities around the country, around the world, and they come in and help you build out these roles and slowly back themselves out. This is obviously different than the evaluation partner. You don't want your implementation team to evaluate their own work. And so what we call it is like we come in as the pilot, we switch to the co-pilot, we move to the flight engineer, and then we're sitting in the back with the passengers, just interested in the plane landing in one piece. And so once you have these sorts of components in place, then you can really get to work on implementing your system. That was a lot. I thank you for joining that, and that's kind of a 101 in the reimagining public safety work that we've got going on. And I hope that was really helpful and not too much of a word salad. Here's my contact info up here if anybody has any questions that they don't want to ask now. But if not, I can jump into the chat.
Thank, thanks, Alex. It's Chloe. Are you able to, if you stop sharing your screen, I'll chuck a few questions your way um, that we've seen coming through. Thank you so much for sharing all of that information and definitely other examples on there that we hadn't actually come across before. So really, really appreciate that. And I think one of the biggest things from our first conversation that really stuck with me was how this has to fit within alternative destinations and the whole commitment to reimagining safety, not just the one thing in a silo. So thank you. Um, with some of the questions coming through, and thank you to everyone. Please keep sending your questions. We are running early, which is a first, so we'll have lots and lots of time for questions. I guess people have been saying that when we have alternative responders, this is the case in Australia, often those clinicians are given powers that mimic police a lot of the times, and that is whether to detain or coerce and choice does get taken out of that picture. So it would be great to hear about alternative responders and alternative destinations, like how has building these systems factored into centre choice?
Yeah, that's a great question. So I think I'll talk like one big example that comes up around choice is around an individual's ability to consent. And so when we see folks who are maybe like they're highly intoxicated and they need to go somewhere, if they're sleeping, a big issue that we have in states, obviously horrible winters, is somebody sleeping outside and basically freezing to death overnight. And so this is something where an individual will be taken to a sobering center, and then they are held until they are sober enough to consent into treatment. And then as soon as they're sober, they can say no and they can leave at that point. But the ideal is that they're out of the weather or they're out of that situation for several hours, and then yeah, when they're sober enough, then they can say, no, I don't want to participate in this anymore. The problem that we find with a lot of like voluntary only programs is that if you call and you don't transport the individual, the next option is still going to be the police. So if they end up going somewhere, it's going to be a much higher risk interaction to take them. So I think there's a balance that has to be put in place between, yeah, we don't want the clinicians to essentially be unarmed police, but we want to also recognize the risk of if this person does go somewhere, or if this person refuses to go somewhere now, and then the next step is probably going to be an escalation.
Thank you. With what's also come through a lot of the question, and I think this mimics as well, possibly some of the things when you say, "Is it nearby?" That question. In Australia, there's a very different reality between living amongst cities and then living quite regionally as well. And I guess how has the Reimagining Public Safety program tried to make sure that there is that equitability outside of also just big cities?
Yeah, I think that's where the use of telehealth, the use of like in-home visits is so important. So, the community paramedicine program initially started as it was called rural paramedicine, because this was something where it was like, we need to get out to places and really engage folks where they're at because we can't expect them to drive all over. And so this is where, again, like if somebody's had a contact with the law, with the kind of emergency departments, the model for the follow-up care is in home, again, in home for the first couple of visits. So I think building that in hopefully reduces the likelihood of a future engagement, but it is going to be tough in terms of like community resources that are available.
And maybe if you can like expand a bit on that. So when you say that started off in rural areas and people visited homes, like what did that program look like and what was it trying to address?
Yeah, so it was trying to address making sure folks are staying on their meds. This is a big one. So do you have medicine? Is this something that we can kind of procure and bring by to make sure that like you're not calling because you've run out of medicine, you have no way to get to the pharmacy. That in a lot of sense that's been addressed now by like pharmacy by mail. But is this something where we can come in and make sure that like your house is set up in a manner that lends itself to safety. This again is used a lot for folks with chronic health conditions as well. Do you have the equipment in your house to be able to kind of maintain your health in a manner that doesn't lend itself to a future 911 call? That was the kind of stuff they would do in person. They'd also come out and do vaccinations and stuff, things that they could do that would reduce the need for you to kind of traipse across town to the hospital or the doctor.
And with those sorts of programs, because we've also had another really great question come through, is a lot of the times in regional areas as well and remote populations, there's also then over policing because it is, a lot more proximity is closer with police services and that does result in over policing as well. So, how did that also work in terms of was it addressing both at the same time, or was it a byproduct, or I guess how does that also look in removing law enforcement from that?
Just to make sure I understand your question, are we talking about in the rural context?
Yes.
How does like pulling back law enforcement address that?
Well, because of over policing as well, even though there's like less resources, often over policing as well. Did with those programs in rural areas, did it address both at the same time, the over policing and under resourcing?
Yeah, so I think the big thing for policing in kind of rural areas, we see this in the U.S. with like the police experience of indigenous communities on the like reservations, is like the first thing is, and this goes back to the conversation about alternate destinations, is documenting where they're taking folks and why. And so building in like criteria-based off-ramps for police involvement, where you can't just say, oh, I didn't take him to the sobering center. I didn't take them to the arrest diversion center. It's if Alex fits this criteria, A, B, C, and D, he doesn't have a warrant out for his arrest, wasn't arrested for an additional crime in addition to this, he goes to Z facility, and it's making sure that we've built those off ramps in as much as possible so that they're able to be re-engaged by the public health system and not just kind of cycling through police involvement.
Thank you. A lot of questions, and this is something that is also in the Australian rhetoric, and I guess when you're talking about this topic right here, there's this constant debate of, when to step in, but then often what gets used is, what about when there's violence, and then we're needing to like unpack this definition of violence. So with conversations around when and how and building these programs, is there a critical unpacking of the definition of violence and what that looks
Oh
like?
yeah, yeah. I think like it's huge. It's a huge conversation that we ran into with like what is and a great example of this is like we had somebody who got arrested a bunch of times for punching side view mirrors in Chicago, and it was nonstop. And eventually, when the first time a clinician went out there, they're like, "Oh, this person has psychosis. Like they're just waving their arms, walking in the street, and they're hitting these. It's not just somebody. I'm not waking up and being like, I'm gonna go punch every window in the street. This is a symptom of an unmet mental health need." And so we were able to go back and engage the dispatch and say like waving your arms, even if you're making fists, is not attempting to punch people. It's waving your arms with fists. Like when we need to be able to interrogate the call a little bit better to identify like is something violent or not. And I think like the urge to look for violence on the calls is also there. So like is there a weapon in the house is a big question. That's always asked. But like everybody has a weapon in the house. Everybody has a kitchen knife. And so it's like, well, is the weapon accessible? Well, yeah, I can walk in the kitchen right now. So, well, is the weapon in their hand? Is like then it's the person has a weapon in their hand. So we need to be able to ask questions that are a bit more defined to identify this, and then be able to split out like yeah, this person's trying to maybe there's like this is an attempt at like a death by cop thing, or is this person experiencing psychosis and has no clue what is in their environment, and like we don't think this is a violence question. And again, like we have examples of unarmed responders doing this forever. The fire department will walk into a building, recognize that a crime has taken place, or there's something that's taken, and they'll back off. If they're uncomfortable, they'll back off. And so like this isn't a new concept of unarmed responders recognizing real safety concerns. And also, like the fire department's dealt with folks for years having mental health concerns without, like having to go through all these checks of what sort of violence is this. So it's not, I just want to emphasize like these conversations have been happening for decades successfully um, with unarmed responders. And it's just something where we need to make sure our call takers are really interrogating the call to figure out what exactly that means.
Thank you. And I guess in similar topic, because this question has received a lot of up likes as well, is how have any of these programs been used to have an alternative first response when calling out to domestic and family violence? Because I guess people are really curious, and something we'll be talking about later on today is this isn't always the first best response either. And again, we're unpacking violence and crime and definitions attached to these, but how do we make people get the right support? Are there any programs through your evaluation and your work that you've seen tap into that space?
It's really tough. So I'll say the most important thing for in the first response space for domestic violence is housing. And like before any sort of alternative comes into place, it's housing. And like the big issue we see is housing for single women who have male children over the age of 14, because a lot of the shelters for women or shelters for the trans community don't allow, they consider males over 14 to be men and that they won't be allowed in the facility. So this is one of those things where anytime we talk about alternatives for DV, we have to pair it with housing, because if it goes wrong and the person goes home, instead of to a shelter that really truly, or a housing that truly addresses their needs, it can go very, very wrong very fast. And then it's going to call your whole program into question. So it's one of those things where the things that we are testing out is how do we use, if there's been an incident and we separate everybody on the scene, is it possible to use paramedics to do the initial screening? Because paramedics are allowed to clear the room to do a medical screening, and this isn't seen as something unusual, which was the big concern for when you have officers separating people. Then the person who did the harm might think that they're being interrogated about what happened. Um, and so that's still very much in the early stages. But again, like I just want to hammer this, that like housing is the biggest thing if you're going to do any sort of intervention into domestic violence.
Again, I guess that kind of repeats the point of when we're talking about this, it's beyond just the response, and to make the response really effective needs to have the whole ecosystem working in order to make it flourish.
Yeah.
Um, a little bit about, I guess, when we talk about currently for us, the predominant first responders are police. Someone has asked about what training is being considered around unconscious bias of police responders when attending an event. And I guess when this, and it's same with what you work on with the dispatch team and the triaging team, when people have criminal records or other existing police records, and is this part of that interrogation, that training, that looking at the phone calls of who's being contacted and why? Has that been unpacked during your time as well?
Yeah, so as part of the kind of performance review process, you pull what we did in several cities, that we pull the actual calls from folks who are deemed ineligible, and we listen to them start to finish. And then with a room of everybody discusses like, do we actually think that was ineligible? Like, what do we think was the concern? Is this something that we can build into the training? I think, excuse me, I think the unconscious bias stuff is very tough to build into the call tree of what they're asking over the phone. But there are things where we can say like, like what, which none of the questions that you asked made us think that you shouldn't send somebody. Like, why did you send somebody? And the person's not going to say, oh, it was a black neighborhood and I was scared of it. But like, so then we can say, well, if there's no reason, like you should be dispatching them, and then allow them to make the decision when they're on scene, like anybody can do already. And so I think like that's why it's so important to have your call tree be as specific as possible. You want to make sure that like a big part of when you put together the questions that you're going through is that you have somebody from a doctor with psych experience looking at the questions. You have folks from a number of different backgrounds looking at the questions to make sure it makes sense to everybody from all walks and cultures. Those are the sorts of things. And then, yeah, like aggressively kind of QI and seeing like, asking the call taker and then being like, all right, well, this person needs more training or something. And this is where building in those percentages comes in. So important rather than just raw numbers of calls you've diverted.
Mhm. And I guess sort of back onto that question around like really critically examining, unpacking, and looking at data is a big trend here in Australia is often, and this is getting like research is studied currently is paramedics or other medic first responders are quite frequently calling police for assistance as well. And I guess was this something that you saw in your work when developing alternative first responders or from alternative first responders? And I guess how did that conversation go in terms of sometimes is the alternative responders calling police themselves? Like, did you also find that that tension?
Yeah, so we're doing a national project on this right now about looking into why EMS units are calling for police backup and trying to understand what's going on there. And again, like looking at why alternate responders are doing the same thing. And a lot of what we found is like it is the kind of like the rumor machine is saying, as folks are listening and they're getting scared um, and this is why it's so important to have diverse alternate response units and to make sure that folks are in the community, that they've learned what's happening in the community, that they're spending time. When we rolled out new units, we did this, what we called the road show, where it's like go to the schools, go to the libraries, go to the grocery stores, go to 7-Elevens where these calls are going to come from, go to the parks, walk around, meet people, and you should be out being proactive enough that you can be like, oh, that's Alex Heaton. Like I've met him 10 times, and if he sleeps at this bus stop. And eventually you build the relationship up that it's like, oh, I'm terrified, because of what I'm reading on the news or something. And that's the kind of thing that we really work to get in front of. And again, is why it's so important to make sure that you don't have just like a racially like homogenous alternate response team.
And I guess I'm sort of sliding in my own question here is because quite often, as this is still something that definitely occurs here on the ground, and not in this same funded, evaluated way that you're talking about, but definitely exists and has always existed here. In terms of the programs that you talk through and the ones that you have run under this project. I guess I just wanted to ask because so often it's seen as like a one for everything, but when delving further, it's actually like hundreds and hundreds of programs that are delivering this. And I guess when you talk about relationships, how important is that it's something quite localized and not a big top-down blanket approach?
Yeah, that's a great question. So I think like the community resources are the local solutions that you connect folks to. And so like when you go, the way we describe it is like when you go to an emergency department, the emergency department isn't going to do your physical therapy if you go in with a broken leg. They're going to set the leg and then refer you to the specialists. And so in that sense, like that's how we think of these alternate responders. They're going to come in, they're going to de-escalate the situation. Can I engage this individual and not transport them anywhere? Do they have to be transported somewhere else? Like, what do we have to do? And then everything's calmed down a little bit. We're going to connect them to our follow-up, and that's going to be connecting them to those local community resources. So I think the importance is in terms of like that those resources are accepted by the community and are seen as something that is beneficial and not like something that's just a jail with a different name. And that's also why it's important to follow up and say like, are people being booted from there? Is this something that like folks are able to get treatment in? So there's going to be an aspect, a top-down aspect of because you want to make sure that like there is standardization across. If there's one organization that's connecting you to medically assisted treatment, and then there's another organization down the road that's connecting you to like prayer-based treatment, the outcomes are going to be incredibly different. So we want to make sure that everybody's able to get the same sort of basic training, and so that everybody can say, like, I assume, similar to right now, I assume if I call a paramedic that they're going to have roughly similar levels and scopes of care, similar levels of training and scopes of care. So we want to make sure that that is standardized. And then there's a pathway, an apprenticeship pathway. Most people can come out of school and say, I want to be a police officer, I want to be a firefighter, I want to be EMS. But like most people can't come out of school and say, I want to be an alternate responder for mental health or a crisis responder. How do I do that? So we want to make sure there is some sort of like national standard for how you go into that, similar to there are for other first responders. But again, then when it comes to the connections to the community-based care, I think that's where it's the most important for it to be like very locally relevant.
And then I think from this, and this is a question that we obviously are grappling with ourselves, and a question that has come through today is obviously that all of this requires investment, right? And new programs, other resources, alternative locations. I guess it comes down to the bottom line is money. And it would be great to hear from you in terms of those in getting these programs discussed, like where did money come from? And I guess is it, divert and divest, or was it getting more money? And like, how did you grapple with that policy ask of we need money to fund this
Yeah.
and
So I
and
think
the
that
and the long-term investment as well?
that's a great question. What we saw in the US was that everybody was excited to start a pilot program so they could say they have something. And then you have a pilot program that's, 20 people big, with a police department that's 11,000 and a fire department that's 4,000. And then it's like, how do we take this from that 20 up to something that's 24/7 in every district in town? And so I think that's still something that's really being figured out. Obviously the change in administration here changed some of the funding calculations for how we get money from the federal government out to the community. So some states are using like marijuana tax dollars to pay for it. There's some states are tying in some of the insurance companies to pay for it. So it's very different depending on what state you're in, kind of what model they're using to pay for it. So I think the answer to that is like it's whatever you can imagine for what you have available, unfortunately, which is not a very helpful answer, but there just isn't a standard funding stream for this yet.
And I guess in still on that topic of design and implementation, I have a question that's come through around user-centered programming and services and designing things and options from a user-centered way. How has this been used and also, I guess, modeled for the programs that you're running?
Yeah, that's a great question. And so we worked with a state that had, or a city that basically was not allowing folks to do overnight sobering and then get into treatment the next day. So they basically had to come in and say, I'm going to stay here for 7 days. And so that immediately excludes what we call like social sobering. So it's like, a kid gets to university, goes out, has 20 beers and gets taken to the sobering center. Like that is a person that is also a good candidate for sobering, but they're not going to stay in for 7 days and miss maybe a flight home or miss school or whatever. And so when we spoke to users, it was like, I don't want to do this because of this. And so we're able to go back to the government and say, like the reason that you're not getting engagement is because the folks who you're trying to engage like don't want to use the structure that you've put together. Like you need to change it in order to make this happen. And so they're able to change it. I think, in some places as we move calls online, there was concerns about connectivity, in some communities, and so it's like, how do we still, how do we work with libraries to make sure there's still a possibility to file these reports in person if folks don't want to traipse all the way across to the police station, or don't want to file a report with a police officer. So then we'd address the connectivity concern, same with language concerns and whatnot. Um, and it's kind of going through and speaking to folks after, part of our evaluation is having the evaluator speak to family members and saying like, how was that? What happened next after this? And part of your second response will do that, like, oh, you connected me to a religious based outreach program, and like I'm a member of the LGBTQ community, and didn't feel comfortable there. Okay, well, let's find you a place that you feel comfortable at. So I think um, there's a number of ways to make sure that we're building solutions that are focused on the individual, because if you do that, you're going to get the most utilization and the best results rather than some sort of blanket like it or lump it approach.
And then with that too, with the, I guess, increased feedback and communication and adjusting and evaluating both through listening to users and data and everything else, did you find when I think back to the components you talked about earlier that the calls to 911 reduced and it was more about that assertive outreach and people coming into contact just by being these services being out and about, or did it still remain
Yeah.
that people felt comfortable using at 911 knowing that they would get a better response other than police or other law enforcement services?
Well, it's both is the answer. So we found that with using arrest diversion, you reduce the likelihood of the individual being arrested significantly following the engagement in services. So that may be because they're not going and maybe purchasing substances anymore because they're on medically assisted treatment and they're allowed to carry it. So if they get stopped and it's like, oh, you've got, whatever, well, I've got a prescription for that as well. So like I'm not going to get arrested. So we've reduced the contacts in that sense. We also reduce the calls for service. I mentioned survival crimes a little bit prior, but for folks who are experiencing substance use disorder, you're going to see call service that come from stealing stuff to go take to the scrap dealer or stealing food from stores. You name it, and those calls drop. Um, but but also like their victimization dropped. They're in a very precarious position. They make easy targets in some senses, depending on what they're using. We see victimizations of that population drop, and then we see their involvement in victimizing other people drop as well. So in that sense, like getting folks into appropriate treatment based on their needs made the entire community safer, including the folks that you got in. And so that reduced police engagement in that sense. And then I forgot your second part of the question.
Oh, that's
Sorry.
that's all good. I'll probably go to our next question, which was with the alternative first responders. So when we're talking about that response, is outside of maybe that uh, medic training or other sort of forms of training, what sort of training are people receiving? Is it around other ways of working, trauma-informed practice, non-coercion, recognizing behavioral, I guess, what does that training look like?
Yeah. So there's a lot of these programs are using folks who come from a system where they're already have a basic level of training. So it's psych nurses who are coming in. Psych nurses are the big one. It's social workers. The reason that you see a lot of psych nurses is because they're already used to working shift patterns and working kind of outside of normal hours. So we see a lot of those guys, and they've experienced the stuff that will scare off folks who maybe are coming from like 9 to 5 roles into this. So they're coming in with a level of training already, and we set the requirement in the beginning, and this is going to have to change in the future as we try and make this more accessible as a job. We set the requirement that you have this level of experience so we can get going right off the bat. And then what we do is we do training on a big part of this is like cultural training on the community that you're working in, tell the history of the community, the folks who are there. We meet with representatives of the community and talk about what's going on. We talk about the assets that are available in the community, um, which is a big component of it. And then we talk about some of the like more common sustained issues that the community is facing. So if you're going to be going to a lot of opioid related calls, so yeah, this has the opioid market, open air market for the community. This says the X number of, X ranking of overdoses that are here. And then, as you said, it's a level of like how to engage with the other first responders to make sure that they are seen as the expert on scene. A lot of times, it's going to be it's very traditionally like whoever has the gun on scene is the person in charge. But you need to come in and say like, no, you are the crisis responder here. Like this is a crisis call. You are therefore the subject matter expert. Everybody else is in support of you on this call. And so these are the kind of things that we train on. And then yeah, it's like trauma informed care, making sure that we're using motivational interviewing and things like this. This kind of training is something that's being built out as we speak to try and build out. Is there like a standard basic training that can get somebody to this level? And then is this something we can do without having to just go to the psych nurse community?
Mhm. Thank you. And I think from that as well, what's there's a really big history in Australia around peer-based support and peer support and roles as well. And I guess with these alternative responder models, is it always one person or is it having peer-based support roles as well? A
Yeah.
bit of A, a bit of B, I guess. Where is the role of peer-based workers as well?
Yeah, so there's some states are testing out like, we see, indigenous communities a big deal. Communities that have low trust in the United States, we have, like there's communities who experience some of like the horrible medical trials in the Black community. Like they all have folks who play the role of a community medical worker, community healer or something. And there are states who are testing out like can we just certify these folks and say like this person, yeah, a peer, but like a peer is going to top out at some certain level of pay or something like what does it take to take this peer experience and to take the experience of somebody who's played the role of a healer and certify them as somebody who can go on these responses. So that's the first thing that I think is a very important component of what's happening right now. And the state of Oregon is doing really impressive work in that sense. And then the second component is, yeah, is like how do we incorporate peers into the response? If it's on the vehicle with everybody, we use that a lot for substance use response. Like the peers are a big component, much bigger than on just the mental health side. And then the outreach teams will include peers as well. Again, because somebody who could say, "Look, I've been there, and whenever you're ready, like we're here to connect you with care."
And I think we have managed to actually get through a lot of questions and get and catch up on our time. So I'll throw one more your way. But for what we've seen come through, there are a lot of people that have asked around youth and young people in terms of the first response and alternative first responders. And I guess what does that look like? And is there a different model or is there obviously different needs and different supports? But where has when we talk about alternative first responders, when there's a young person on their own,
Yeah.
what has played out?
Yeah, it's a great question. So I think a lot of municipalities will have different extra steps that you have to take depending on. So we have what's called like tender age. We have like adolescents, teenagers, and so like based on where they are is what, like sometimes like you take them home to their parents and then like, okay, what do we do from here? Um, for as they get older, it's like we can engage them in treatment and tell their parents that they've been, maybe connected to a triage center for kind of they were in need of a triage center, taken there and connect. And obviously, as they get older again, it's like you ask the individual, like we can notify your parents and we don't. I think it all comes down to as well, like what does the alternate destination facility, what are they willing to take on in terms of children? Some municipalities just say, look, if they're below 18, like they go to the hospital and the hospital does all the screening there, just because of the kind of risk and also collecting data on juveniles in the United States. There's a lot of extra steps you have to go through if there's a justice component of it, normally with the permission of a chief judge. So what we want to do is still make sure that they have an opportunity to be referred into care, and but respect whatever the local jurisdiction's laws are based on those brackets of how young they are.
And I think we'll slide in one more question as well, because I think someone raised this point the other day and it was sort of the rise or the death of the drop-in center. And I guess you talk about outreach and the importance of also having assertive outreach versus the other way around. And I guess moving forward is what are you seeing in your work? And I guess how do we keep pushing that we have these because I also think alternative spaces are almost that just go hand in hand. It's not one's more important than the other, but how do we stop this move away from, and are you seeing a move away from investing in alternative places and drop-in centers, places people can just go and be?
Yeah, so that's a great question. I think like we ch- uh, the suggestion is really that you combine them with other things, right? So like a big push in over here has been like observed opioid sites. where you can take opioids in a space that is going to be observed by medical professionals. But there's a lot of pushback from the community saying, like, are we just going to have a bunch of people leaving dirty needles outside? And unfortunately, in some places, there were examples where they saw these needles. And so what we said was like, how can we incorporate these treatment facilities into a place that has multiple other public health services as well, so that it's not just known as the place where you go to take opioids. And so like building that in and making sure again that like for first responders that it's criteria based, that if they fit the criteria, they're going to these facilities. And then making sure that there's a patient education component or an education of the family component that says, look, we're taking you to 123 Main Street, which is the triage center for individuals experiencing mental and behavioral health crisis. You can also take them there if you want without having to call 911, and they can take themselves there if they need to go and de-escalate and be outside of the house. But it's really an education of the community on how important this role is, but as well as in parallel with telling our first responders, you shall take them there if they fit the criteria, not you should if you want to, or whatever. I just can't overstate the importance of having a criteria-based program instead of discretion for the use of these alternative centers.
And I think one more before we wrap it up to have our break and stretch. But with this goal of having 12 million phone calls diverted a year, I guess how close are you to getting to that goal?
Well, it's very early. We announced it this summer.
Okay.
But yeah, our game plan is if we can get 100 municipalities in the country to divert 20% of their calls from police to alternate responses or to like non-dispatch call resolution, we expect to have 12 million calls diverted by 2030 is the game plan. And then, we'll look and see what that does to, to kind of people being killed as a result of calling 911 or and what happens to other calls again, like does it follow this pattern of other calls becoming safer as we reduce the uses of force for folks who have primarily healthcare concerns?
Okay, thank you so much, and thank you so much for your time. And I wish we could get through so many more of the questions, but you're so generous in sharing. Maybe we can share it somehow post-event, your QR code. So if people want to keep asking you questions, you've opened that that door, and I'm sure you'll get lots and lots of questions. So thank you so much for joining us today,
I appreciate it.
and thank you everyone for engaging in the Q&A and allowing us to have this really, really robust discussion. And we will be taking a break and stretch for about 20 minutes. Sit, think, share, talk to your colleagues, to the people around you about what you've learned. And then we'll be back with Gina from Canada speaking about her journey in converting into community responses away from police in remote Canada. So thank you, everyone. And we'll be back at 11:30 Sydney time. And we look forward to keep sharing with you then. Thank you.
Thank you.